for Metabolic Surgery. Headed by Dr. Raman Goel, Center for Metabolic Surgery is among India's top bariatric center. CMS represents a comprehensive team of surgeons, physicians, dietitians, psychologists to assist on weight loss surgeries. So every Thursday, same time, we shall be hosting clinical discussions around obesity management. This program will include the expert opinion of our guests on the topic, along with the patient testimonials and experience sharing about the treatment. Today, we will be discussing about the etiopathogenesis of obesity. Obesity develops in an individual with energy intake exceeds energy expenditure over a prolonged period and the excess load as tried predominantly in adipose tissue. The rising prevalence of obesity is a worldwide problem, and to understand the pathogenesis, it is important to understand the regulation of energy balance, which although very tightly regulated, is subject to biological variations. To throw light on this, our speaker and guest for today is Dr. Chandaliya. Dr. Chandaliya is currently the director of Denmark, that is Diabetes Endocrine Nutrition Management and Research Center, and the director for endocrinology, diabetes and metabolism, Jaslok Hospital and Research Center. He was on the faculty of Grand Medical College for the past 30 years. A passionate teacher, orator, and prolific writer, he has brought Indian diabetes journals, books, and magazines to international levels. He has been an active researcher as well. His research interests have been glycation, lactic acidosis, obesity, and diabetes education. He has published more than 80 articles and authored, edited, and contributed to more than 50 books. His painstaking effort towards self-management and empowerment of patient education is evident from his keen interest in being the editor of Diabetes Today. His leadership abilities are reflected in his campaign to establish various long-lasting organizations and undertake pioneering projects. Without further ado, I would like to welcome Dr. Chandaliya to speak. Welcome, sir.
Thank you. I'm audible, and yes. Thank you, Dr. Plexus, for inviting me to this session of obesity and management. First, I'm very happy to be here and associate with Dr. Plexus and my dear colleague, Dr. Raman Goel and Hema Parmar as speakers. Now, what I'll do today is really speak on the causation of obesity. And sometimes someone starts discussing etiopathology. Clinicians think that how would it help them? But let me tell you as we go along that your treatment, if it has to be rational management, that it has to address the issue of etiology. For prevention, of course, this is the most important thing, to really prevent the problem ab initio. So I will go on giving you very good clues that why we manage obesity in a certain way, because basically at the present time, I'm a clinician. So I'll present it in that form. So you will have some very interesting clues as to how you should approach the problem of obesity. Can I have the control of changing? Okay. Now, at the outset, let me remove this very small group of obese people where there is a very clearly identifiable endocrine cause. Because why I do that? Because many patients take refuge in explaining their weight gain into one of these, and especially in thyroid disorders. They ascribe it to their thyroid disorder, although their problem is the usual obesity, which is, of course, you see, jointly present with hypothyroidism. So remember, people who do that, hypothyroidism makes you gain hardly 2-3 kilos of not true weight, but water and some mucinous tissue around the body. Cushing syndrome, hypercortisolism, you see, can cause some degree of obesity, but again, not much of fat collection. It's water, edema, and so many other things. But insulinoma is a true weight gain, a real bad weight gain, which can be massive. The insulinoma extremely rare. So I'll dismiss them very quickly. And in polycystic ovarian disease, obesity is often one of the three main components, which are obesity, menstrual irregularities, and hormonal imbalance causing androgenic changes. So we leave it at that. But many patients will keep saying that I got PCOD, so I'm gaining weight. Remember that PCOD can also exist without significant obesity as well. So now we come to the basic causes of obesity, which is very complex. It's a huge obesity is a huge problem. I don't want to go into epidemiology because that is not my subject today. But it is huge problem of huge people, and I always call this area of obesity as one of the darkest area of medicine, dark area of medicine. Still, it is dark. We need to throw a lot of light in this area. As we go along, I'll show you where we still have problems in understanding this disease, because obviously we need that understanding to develop some good approaches to management. So mainly genetic and environmental factors, which we keep talking about. So the normal person, the gene and environment are different side. Then there are many other features come because of this gene and environment interaction. And quite often, many of them are listed as a cause. They are not causes. They are markers. They are manifestations of obesity, like insulin resistance, decreased insulin secretion. Some of them will get diabetes. Then there are a lot of diabetogenic genes. We see, look at some of those. And of course, the environment is extremely important. Why we lay so much emphasis on environment? Because that is something which can alter at the present state of our knowledge. To alter genes and gene therapy only sometimes may be possible soon in some monogenic disorders where one gene is involved. But obesity is a very complex, it's a polygenic disorder, so it's very difficult to do that maneuver. Now, these again, like metabolic syndrome, we sometimes keep talking in the same breath, obesity and metabolic syndrome. Metabolic syndrome is a different story. It's obesity accompanied by three other sinister problems: hypertension, high triglyceride, and also low HDL, insulin resistance, and you see, so and high insulin levels. So these are features of metabolic syndrome. So obesity is a component of that. And you can see all the others listed on the other side also are sometimes all part of metabolic syndrome, but people are mixing up causes with the intermediary proteins alterations, you see, and all. It's a mixed up issue unless somebody, speaker or author, is clear in his or her mind. They mix up everything and just call it metabolic syndrome. So this is insulin resistance. That means insulin doesn't make you burn same amount of glucose, and especially the resistance at the level of skeletal muscle. And by that, the exercise becomes a very important component of therapy, very important component, because muscle is the main site of resistance. But of course, there is resistance in adipose tissue as well as many places. And of course, now, how much it is heritable, to what extent? Because patients would like to know, doctor, I'm obese just because my parents, grandparents are obese, or you think I've done something wrong. And you have to have some clear ideas as to what is the truth. And the truth is based upon large number of studies on twins living together or separated with different environment and sharing the same genes. And only on the top, the two are for obesity, rest are other diseases comparable. You can see the heritability component of obesity is rated at 0.77. So at every moment we ascribe the small 1/3 part to really the non-heritable, that is probably the environmental. But as I go ahead, I'll tell you more complex issues, because sometimes the environment also works through epigenetic phenomena. So the gene's expression changes. So this is something very important to understand in the causation of many diseases. So overall, there is a lot to do. I want to encourage you to understand. It's a frustrating problem for you as well as patient, but there's a lot to do because the environment can be manipulated. At least we have capability to do that very effectively. But unfortunately, we fail because the problem is a tough one, recurrent one, relapsing one. So it does cause a lot of difficulty in practice. Now I've passed on very quickly to 4 slides. So these are all monogenic obesity. Like some of the syndromes, you doctors must have heard: Prader-Willi, Lawrence-Bowen Biddle, and 5 of them are shown. And these are clinical features of them shown. What kind of inheritance, stature, obesity. So they are characterized by some clinical features, phylogenetic feature. So those can be these children. These are children obese children who will be always diagnosed by the pediatrician. But let me tell you, they are rare, so I will discuss them very fast. I have to go to the bulk of obesity where causes are not so easily evident. And then you have obesogenic gene, some of them common to human and mice, very interesting. The leptin, you see, being less is called obese. obese mice and similar, maybe human model obese with leptin deficiency, and leptin receptor resistance is another one. The diabetes is also added. So the diabetic. They are not obese, diabetic. And there are many other genes which have been experimentally looked at in mice, and similar parallels are being drawn in human beings like PC1 hormone, convertase, so many. But let us dismiss them fast for something more substantial, which will help you in practice. So this is how the obese, both genes are both the homologous genes are leptin gene lacking and leptin receptor lacking. Okay. Now, most important thing, it is not one gene; it is multibunch polygenic. So there are see, remember in genetic disorders, susceptibility genes and necessary genes are common, are different. Susceptibility genes only make you prone to. So many obese people may not have those genes, and many people having susceptible genes may not have obesity. Necessary gene almost surely brings out the disease, and it has to be present in the disease person. Most of these in obesity are susceptibility genes, you see, and this is very, 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 very important area of understanding epigenetic phenomena. They do not change the DNA sequences. The DNA remains same, but they change the expression of DNA, expression of genes or DNA, by adding a methyl or acetyl group to the histone skeleton of the helix, the DNA helix. So that changes again many phenomena, starting, stopping, terminating sequences of protein synthesis, and changes the whole story. Very interestingly, if you read in the literature, epigenetic phenomenon, like in bees, the worker bees and honey bees have same chromosome. The honey bee commands because there is something epigenetic happening in one of those 100,000 maybe, and that person becomes a leader. So I think so epigenesis can do, epigenetic phenomenon can do all that. Now, genetic factors, how do they work? They will work through different mechanisms. See, the genes will work through, of course, the proteomes. So genomics, you have to go to proteomics. What abnormal genes those proteins they are making. So these mechanisms are a huge subject of studies. And satiety mechanisms are very important. So many drugs were developed to control the satiety. See, and they say all the medical treatment for that. Unfortunately, in this area, we have singularly failed because quite a few very, very prominent molecules during my career of about 50 or 55 years, about 4 drugs have come and gone. They were marketed, not only research, they were marketed for 2 years, 5 years, 10 years, and withdrawn. So a very, 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 very disappointing area. Working on adipose tissue, now we know that human beings also have brown adipose tissue, very small amount, and white adipose tissue. It's possible for white adipose tissue to be converted to brown. The brown is metabolically very active adipose tissue, and therefore can burn the calories and prevent obesity, while white adipose tissue works differently. So this is again another area of research. The protein energy expenditure, very interestingly, uncoupling protein, thermogenesis, wasteful pathways. They were described some time ago. You don't see as much work on that until we get some breakthrough. But you see, you see oxidation cycle going on in which uncoupling proteins can waste a lot of energy and generate more heat. So remember, by this I want to point out that when you take history of your obese person and the person says, I only eat this much, do believe him, do believe him. A lot of good experiments, some of them I conducted long ago in a metabolic unit in US. You see that under lock and key, they remain there for a month, 2 months. The patients take leave and come for study, you see. And there we find that on 1500 calories, some people can get tremendous weight and some people will start losing. So there are some areas of metabolism not as fully elucidated or quantitated. And if we have good ways of correcting those pathways, you may really remember that give a lot of thyroid hormone with some of the quacks in Mumbai, obesity quacks produce thyrotoxicity in my patient. In the Ayurvedic powder were contained something like 10 tablets of thyroid. You see, and the person started having fast heartbeat and came to us, and we realized that, and that uncouples oxidative phosphorylation and waste energy, and you start losing weight. Hyperthyroid people lose weight. So this sort of tricks are possible. But if you understand this, you can detect, okay, this is what has been given. So I immediately detected that person has given you a lot of thyroid hormones, and we measured in the blood, the levels were very high. Now, all these things, I think, feeding, and these are very complex, very complex. One obesity expert we had called once to together to do a seminar in Mumbai, you see, and he gave me a chart which occupied one big wall, and the pathways were all on the whole wall. So very complex hypothalamic, lateral nuclear, medial nuclear path, and how this acts. The adipocyte is the endocrine organ. Slowly, we endocrinologists say not only those endocrine glands that you know regularly, but also we think adipose tissue, brain, gut, they're all endocrine organs, endocrine cells, very, very active there. And leptin, adiponectin, those are very leptin. I mentioned earlier, there can be a difference in the metabolism of cortisol in the adipose tissue. And then, of course, adipose tissue produces a lot of interleukins and C-reactive protein, TNF alpha, which you know are damaging. We know these molecules very well because of COVID now, that they can be damaging molecules. They cause a lot of damage to the cells by free oxygen radicals. So adipose tissue can secrete all these hormones, the fat tissue. So fat itself is a big subject of study, and these are too complex. I don't want to bother you with that. You see, this is important. Environmental factor I come to, because this is what we are able to do. So we focus on this. So you see, high food intake based on some of these things. Very important, high calorie infant formula, which were later on shown about 30, 40 years ago, and all milk manufacturers told, you see, that please reduce the calories, children are going fat. Of course, and all this is very well known to you, so we pass on. Always remember that human metabolism defends body weight against scarcity. So when there is famine, you see, our metabolism for millennia has been geared to save ourselves in case of scarcity. Because plenty of food all over the world is only a recent phenomenon. And even now, there are areas in the world where there is starvation. So you see, so we all adapted to surviving in starvation. But we don't have mechanisms yet develop or evolve. I hope it will evolve by some epigenetic phenomena where we can start eating, and those fellows will have to never see us and bring down some change in the genes. But scarcity more efficient than against food abundance. So now we have the problem of food abundance, and that is causing problem. Life situation causing obesity are very practical to understand. Each pregnancy is a weight gain. After first of all, during pregnancy, woman is fat. After during lactation, they are told you eat for two because you're breastfeeding, and mother-in-law and mother conspire together to produce obesity in this beautifully looking woman during her first pregnancy and delivery. And after that, she permanently 10 kg plus with one month. Luckily, now there are 1, 2, hardly ever 3 nowadays in most part of the country. Slowly, this is catching up. So this is not causing as much obesity. Post-delivery period, they are fat, and then fractures, they lie down in bed, you gain weight. So some of these, the time you have to be careful. And change of life and eating out. When you address the issue of dietary intervention, you always have to find out how many meals per week are eaten out of home. Because controlling your food outside the house, in a hotel or restaurant, ordering the correct food, doing the ingredients in a very complex mixed dish is very difficult. Sometimes I think you should not hesitate to call the chef and find out what is gone into the dish. If you find a very exotic and enticing name on that dish, see, of course, switching to a certain job change, and some drugs can cause tremendous weight. Oral contraceptive. Not all women, but some of them start gaining weight in 6 months, 1 year, and I think it is our duty to immediately stop and use some other method of contraception. Corticosteroids always do that. Glitazone in our diabetics. Not everyone, but many people gain weight, and there is age-related weight gain also, which keep talking. You have to do energy cost, because when you plan exercises, you want to burn certain calories, like 1,500 calories per week, you see, in exercise sessions. So when you plan that, you see, you really make some calculations and make sure you're given the correct form, intensity, duration, you see, and frequency of exercise. So exercise prescription is a very important component. As diabetologist and practicing some obesity, you see it side by side, because almost 50-60% of diabetics are obese. We all master proper exercise prescription. And in order for that to be effective, remember, if possible, I exhort all of my colleagues to learn exercises, do exercises, because it has been studied that those doctors who are doing exercises are able to prescribe properly. You see, so I think it's very important, simple fact, but learn to do that. Now in India there is a peculiar phenomenon, and we have all gone through, you see, a very interesting subject for last about 30-40 years, and that is the intrauterine origin of adult disease. Adult diseases which origin is in uterus during pregnancy. So that nutrition during pregnancy is very important. Started by David Barker's work, and in our country, very, very interesting and phenomenal work by Dr. Yajnik and his team, that undernourished rural women, you see, with small for age babies, but having excess fat compared to muscle mass. So muscle fat ratio is poor, and they later on have more chance when they have plentiful food available and nutrition improves, they have a chance of getting bad obesity. So the problem of obesity can start from there. It is seen in the school children, then it is seen in the all ages, at all ages. So it's a tremendous problem. I must also just add to one more aspect, and that is the gut flora. Gut flora is a new subject, and there are certain gut flora which you see would increase obesity, like that is Firmicutes type, and there is also the other organisms which will reduce obesity. So there is a possibility now of the most easiest transplant, that is fecal transplant, getting promoted. Hopefully not the feces, but the bacteria which are helpful in making you lose weight. So they can change a lot of energy movement in the body. So they make also a good amount of our body, the good amount of parasites in our body. So these are some of these things looked at. Can you see how many diverse area of research are there and all that? But what is done in practice is some of the things I told you, see, and that is really changing the environment. I do not want to say much on bariatric surgery, because many of you people have obviously from that stream of our medicine. But you see, I've seen that if we fail in controlling somebody, then the weight is BMI of about 35, 40, and in India even 2.5, less than that also, and comorbidities, I think it is indicated. The repeated failure of your conservative efforts, you see, and relapses, I think is an indication to go for that. But and it's a wonderful way of losing weight. There are little bit relapses after 10, 15 years being described now, but still it is after 10, 15 years. So they are good weight loss. They are all very cheerful. It changes hormones in the body. It changes peptide YY. It changes ghrelin levels. So now we are studying how those hormone changes bring out. Can we capture that biochemical changes and transform into a medical treatment? We are not trying to put Dr. Raman Goyal out of practice, because bariatric surgery will still continue very long. But it's like peptic ulcer. Ultimately, we found this H. pylori, and we treat that, and peptic ulcers are gone. So, but that is a vision. I think it's going to be too far for us to really put that into practice and capture all very intricate biochemical changes that occur with bariatric surgery. But they are very fascinating on my side, on internal medicine and endocrinology side. See, so I think, but also I want to tell you that the lot of manifestations of obesity alter by just about 6 to 10% body weight loss. It doesn't have to be ideal weight. Ideal weight is a dream, it is, it may never be attained, but it is not required. So majority of people, 6 to 10% body weight loss, which is a feasible goal you can achieve by a basic understanding of all this and using appropriate tools, and certainly apply even this, which is often patients don't easily give it in very difficult cases. Definitely bariatric surgery if you wish any degree of success in those people. So I will not go into details of that, but this was some of the insights I could give you. And if I have stimulated you, read a little bit about causation and understand patients' problem a little better, you'll be able to give them some solace, because they are very distressed people when they see you with repeated failure. So to sum up, genetic factors, but environmental are not, but environmental factors are modifiable, and thus giving hope that it may be possible to treat obesity. And identification of mechanisms by which gene and environmental interaction leads to obesity will ultimately give us tools to deal with obesity more effectively. Currently, these mechanisms are not too well understood, and our tools are only partially effective. So thank you very much for your patient hearing. And if permitted, I'll take a few questions now or at whatever stage.
Thank you so much. Thank you so much, sir. Thank you, Dr. Chandaliya, for your talk. It's always a pleasure listening to leaders like you. So we have a couple of questions for you. So the first question is from Dr. Advaresh Pandey. He wants to know, what are the significant and proven causes and ways of managing obesity?
See, I told the main causes are genetic and environment. If you want to very simplify, nature and nurture is a constant sort of debate going on for many decades now. Nature and nurture. Nature is genes. Now we say genes. And so genes and environment. So those are the main. And as genes, you can't change. So I think concentrate on environmental changes. Environmental changes with lifestyle changes, drugs which will change the metabolism in the body. See, that is environment. Surgery that will change the. So you have to use those, but the causes are environmental, and there is a tremendous potential of prevention also. Remember, it is really ultimately prevention has to be applied to the massive problems like this, massive problems. So there are a lot of steps we taken. The food is becoming less calorically, but food industry goes on playing games and adding things with obscure nature and making claims. It's like you do toothpaste with something and your strength will increase, muscle strength. You know how that chemical. Nobody objects to such advertisements in India. You do toothpaste with one toothpaste you use and your muscle strength, your tooth will be better and your muscle strength will increase. It is theoretically possible, but it's too far-fetched. You see, so all these things are there. So I think it's a tremendous problem, and it needs activists, public health workers. You see, physicians, surgeons, healthcare workers. It's a massive problem. So main approach is some of the clinical hints I gave you, and they remain very classical. So tedious, often unsuccessful, but we have to find ways to make it success. We say lifestyle is not possible to sustain. But why don't we do more research in promoting lifestyle, adherence a little better? We ultimately have to change minds, Leaders change mind. That's how they lead country, they lead the world. They need China the way they are doing. See, they change minds. You see, so we can change minds, we can do a lot of good, Like Xi Jinping, if you can do, you can change the world. So there should be some Xi Jinping to do that. You see, so I think research is required in all areas. Psychology, behavior. You can see what a vast area. Because I just wanted to stimulate your idea, because it's impossible to talk about causes of obesity, and more causes are being looked at. When the area is obscure and dark area, too many hypotheses, too many things. Slowly they are laid to rest. So watch. If you live long enough, you'll watch a lot of changes in the area.
Sure, sir. So I think that brings me to the second question, which is, many people blame the change in metabolism for the late onset obesity. Is it a fact or a myth?
It is fact. It is a fact. So some of those genes may work little later age. So there is some genetic factors. Overall, by big population studies, heritability is almost 0.7. So 0.3 is environmental. But this will also change as we go along. Because over thousands of years, as I told you, the gene expression changes. Otherwise, how do population change? Interestingly, during World War, there was siege of France, siege of Norway, and people starved there, 30% of calories for years. And they became healthier regarding obesity, hypertension, many things. Their children, their grandchildren had those effects. How did that come? They were having plenty of. It was the epigenetic changes made in those long starvation period. And so it is very interesting how this can be passed on. We think only genes are passed on. Epigenetic phenomenon can be passed on also. So you can change the population. So slowly, those diseases were found into the second and third generation less. So these are again some of the areas. So along these ideas, we have to develop our approaches. But day to day is still good old lifestyle intervention, anti-obesity drugs, exercise, and the last of all, bariatric surgery. These are the mainstay of treatment. But different persons are different. Genesis is different, environmental factor different. You see somebody eating out, somebody having problem cooking himself, eating some ready food, loaf of bread, a bulk, a lump of butter. And all these things happen. So you have to go into great history. It's not that simple pro forma die where you write a little bit and it's a very complex disease and difficult to treat. It's a challenging disease.
Yes, sir. So the next question is from Dr. Vasudeva. He wants to know how Valparin and medicine-induced weight can be controlled.
Difficult. There are many drugs, anti-epic and the antipsychotic drugs, which can make people gain weight tremendously. And those drugs are essential because if you take them out, the person is in a bad shape. So don't do that. Okay? They're causing weight, try to reduce. You reduce it and you find some disaster happens. So probably when you prescribe them only, to my mind, the psychiatrist who sees the weight gain should start liaising quickly with an obesity expert or a nutritionist, lifestyle interventionist. You have to do. Once they gain, they lose, and it's intractable. It's disaster. You see, person is schizophrenic and then puts on 20 kilo weight and disabled further. It's terrible. It's very important. You have to prevent. We have to liaise with multi-speciality instead of practicing alone. Take help from colleagues. None of us is fully capable of addressing such complex issues. But this sort of thing, camaraderie between colleagues, referencing, learning from each other, in our country is at a very low rate. All over the world, people are egoistic. So this is human behavior in general, but ours is a little extreme. We are individualistic, and we all think each of us that we are the best. See, so I don't know. That comes in our way of learning. Yeah.
That brings me to the last question for you, sir. So, can you elaborate more on the alteration of gut flora to combat the obesity problem?
Yeah, I think these were a lot of experiments done almost 10, 15 years ago. One oration for that RO, my oration in Ahmedabad was on flora and obesity. And very good experiments and studying. You see, the whole gut microbiome is now that can be studied. Techniques developed quite well. So a lot of literature developing, big body of literature. So many diseases, energy metabolism can change by that. You see, gut bacteria can generate more short-chain fatty acids, which are beneficial, and all that can be done. It is known in India, there was a study long ago that poor laborers, who are in a negative protein balance, apparently from your nutrition angle, but can maintain their muscle mass. They are conserving the gut bacteria, are conserving protein. It's very interesting. So it's baffling, you're only making that positive, negative, and you don't know what's going on. Energy balance, which is very simple, principle of thermodynamics, it has changed completely. There's tremendous complexity there. So these are all been studied, they are mapped out. Some are diabetogenic bacteria, some are causing other diseases, and this is very important. How to change them, or do that fecal transplantation. So difficult to do liver transplantation. Why do promote fecal transplantation? In Bombay, it happens in the normal water supply. So what flora you get? Nowadays we become a bit better, but but there are mixed flora. I think it's interesting. It's an interesting area. Looks very funny, but these are being researched very active.
Also, sir, thank you so much for the talk. I think you answered all the questions very well.
Thank you.
I would now like to invite Raman Goel to the panel. So, Dr. Raman Goel is a pioneer in bariatric surgery specialist in India who pioneered laparoscopy surgical practice in Mumbai. Dr. Goel is also the member of the special board for NBE. He was trained in bariatric surgeries from France, USA, Australia, Switzerland, and Brazil. Dr. Goel was also invited to set up a bariatric surgery department in the largest private hospital, that is Bombay Hospital, in 2002. Dr. Goel is the editor of the Bariatric Journal and has participated in a lot of talks on COVID-19 and its prognosis in obese and hypoglycemic patients. He's also the immediate past president for IAGS. Welcome to the program, sir. I would like to invite you to deliver your talk, sir.
Thank you, Dr. Darshika and Doc Plexus, and I must thank Professor Chandaliya for such an elaborative talk on a difficult topic. Dr. Chandaliya and I go a long way when we work together in RO, and actually before that, RO is the National Association for Research in Obesity. And we organized the Asia Pacific meeting in 2009, and where he was the scientific committee chairman and I was the organizing co-chair. And I'm so impressed by his grasp of subject that I thought to start this second series of obesity management talks for family physicians. He's the right person to give it a good start. So thank you very much, sir, for agreeing to join today and sharing your experience. For the last 21 years that I have been in obesity management, even though I am a surgeon, it's a learning because we have seen so many changes happening every 5 years. As Dr. Chandaliya was mentioning, drugs came, drugs went. Even before by the time they were launched in other part of the world, some complications started coming and they were withdrawn immediately after being launched, kind of situation. And similarly, understanding disease is also changing. Our association was founded by Dr. Vinod Dhurandhar, whose son, Dr. Nikhil Dhurandhar, found a virus called AD36, which is believed to cause obesity. And now we are already talking, so people were making fun 15 years back that how can virus cause obesity, and now we are talking of gut bacteria causing not only obesity, even diabetes. So I think it's good to be modest in because you realize what you believe is not possible might happen in one day. So today I'm not here to talk about bariatric surgery at all. I'll briefly speak a bit about why obesity should be seen as a disease and not as a lifestyle problem. And I have a very short presentation so I'll start my screen share now. And hopefully you are able to see that.
Yes, sir.
So this is our Center for Metabolic Surgery, which is at Wockhardt Hospital in Mumbai. And we are starting this series, which will have 24 modules over, so 24 lectures over next, let's say 6 months, I believe, since we'll have one every month. And my topic of the day, we'll have 4 every month. So we'll have a topic of the day is obesity, a disease. And as she mentioned, we are designing the DNB program for the National Board of Examination, and we conduct training programs on bariatric surgery in Mumbai. And our program is the only university-approved program for a fellowship program for bariatric surgeons in the country. So friends, there are so many myths in obesity, and probably the most important myth which everybody has to accept is that obesity happens because of lack of willpower. So when patients come to us for consultation, a typical approach of the family member is that if my mother had been eating less, or if she eats less sweets, then, or if she exercises, she can lose weight, and it's because she doesn't have the willpower. I think there can't be anything much wrong about it, because as Dr. Chandaliya was just mentioning, there are environmental factors, which is fine, but there are a lot of inherent factors, and that is why we call it a disease. And in few slides, I'm going to talk about it. So obesity remains a multifactorial disease, as he has mentioned very nicely in last 15, 20 minutes, which includes the genes, environment, behavior, psychology, physiology, metabolic changes. And there are various environmental drivers to obesity. Now, as food supply is a driver, but this is more in terms of signaling than in terms of overall calories. So we give a lot of emphasis on the calories that are supplied, but at the end, it has a direct impact on hypothalamus, and it alters the signaling to brain, and that is one of the reasons why obesity happens. The second environmental factor is the physical activity. But again, this is more of an issue in terms of muscle mass than in terms of burning of calories. Because as I will show you in next one or two slides, how the exercise has a very limited role to play in terms of calorie expenditure. Stress and distress. So the stress, and this is patients know it much better than what we know as physicians. People say that when I'm stressed, I put on weight, and we say, because you are stressed, you are probably eating more, and most of them agree, and we say, yeah, that is the reason. But stress itself has been believed to cause obesity by directly working on the central nervous system. And as somebody rightly asked the question of the role of drugs, and there are many drugs which cause weight gain, and they are a challenge in today's time, because people are psychologically disturbed, many of them, and they are taking medicines. They are rightfully prescribed these medicines, which also lead to weight gain, besides the usual culprits like the birth control pills. Now, the energy balance, is it because of the behavior, or is it because of physiology? So we all have been taught right from beginning that weight gain is a balance of calorie gain versus calorie lost. But is that true, or is it because of the inherent physiology of the person, that some people with the same amount of calories gain weight while others do not? I mean, Dr. Chandaliya just mentioned that in US, where he was working, there people were locked up, and they were all given 1500 calories diet, and some of them gained and some of them lost. So there are things beyond just calories, and that is what is physiology, which is so important. Now, what we need to understand, and I'm not put the references, but because we will be covering each of these aspects. We will be covering energy, the exercise as one module. We'll be covering diet as a separate module. So what we need to understand is that energy is a very highly regulated part of our body. So there was a study done in Tanzania where they found those people, the Maasai tribes, who are very tall. They are very slim and fit, and they can run. They run. They are hunter gatherers. They run and they kill animals with their spear, not with guns. And it has been found that though when they are running, they burn much more calories, huge number of calories, but when they are not going out for their hunting expeditions, they are absolutely in a idle mode, and they are not burning calories. And when their calories were calculated, it was found that overall in a day or in a week, they burn the same amount of calories what a software person sits and does burn the calories sitting on a computer. So the average number of calories that is spent by somebody who sits on the computer 16 hours and the hunter is almost the same. And why this? Because this body automatically puts the person who is spending more calories, put him in an idle situation later on. And thus energy expenditure has been told to have not big impact on weight loss, though it's an important determinant of weight maintenance and weight regain. So we will be discussing it on one of the modules. I'm just giving you a primer today, what is going to come in next 2024 talks. Now, another thing is the how does the diet works. Now, this study which was done and published in New England Journal of Medicine shows that these people, when they were put on a diet for about 10 weeks, and then they were put on a weight maintenance diet, almost all of them gained 50% of weight in next 60 weeks. 50% of weight is regained, and there are many studies which shows that even an overweight person gains back 92% of them regain their weight within a year's time. Overweight person, I am not talking of obese and morbidly obese. And thus, the diets have limited role. They have an important role for comorbidity resolution, because as Dr. Chandaliya and as mentioned, and there are many publications who say that even 5 to 10% weight loss is enough to improve the comorbidities. But if you are looking at a weight loss, the recidivism is high, and that is a challenge. How do we patients maintain weight with diet? And we are going to discuss this detail in one separate module. We need to understand why diets. It's not the lack of willpower that person starts eating rich food or calorie dense food or larger quantity of food, because the body's physiology opposes diet induced weight loss. So these hormones like ghrelin, so if the person is put on a diet, the low one is the normal person, and when the person is put on a diet, the ghrelin level, the blue one, is the one where at 10 weeks the ghrelin levels have gone up, and because the ghrelin levels go up, the person is more hungry and is bound to eat food, increased quantity of food. And all these hormones, amylin, PYY, CCK, all of them conspire to make sure that the person doesn't lose weight or rather regains weight. So जैसे बोलते हैं कि कायनात काम करती है कि the person's weight loss with diet doesn't succeed. So this brings us to this particular aspect of set point theory. Set point theory has been in vogue for a long time, but what is important to realize is that body tries to maintain a stable adipose tissue mass, just like how the body tries to maintain a liver mass or number of the red cell blood cell mass. The same way it tries to maintain a stable adipose tissue mass by various mechanisms, as we have discussed two of them: exercise and diet, and the hormones related to to eating. This is what happens. So suppose a person is at 30 BMI and with lifestyle changes brings his weight down to 25 BMI. What happens is this energy expenditure, which was here at 30 BMI, starts going down. And obviously, he is reducing his calorie intake and the energy intake starts going up. So the person was eating less at 30 BMI, was spending more, but when he tries to lose weight, the reverse happens, and that pushes the person again toward 30 BMI. And this is what the body fat storage set point theory says, that the body tries to maintain its weight when you do not change the set point. Now, how does the set point work? There have been some animal studies. This is a study done in US on rats, and these are the rats who are normally fed, who are allowed to eat whatever they were allowed to eat, this black line. Now, there were a set of rats who were given limited amount of food and they started losing weight. Another set of rats who were who were overfed, forcibly overfed, and they gained weight. But the moment these rats who were overfed or underfed were allowed to eat ad libitum, that means they were allowed to eat whatever they wanted to eat, the underfed rats started gaining weight and the overfed rat started losing weight. So the idea is that over a period of time, they came up to almost the same weight, which otherwise the rats who were not overfed or underfed were after 150 days. So this is what the set theory is all about. If you are put on a diet, you are bound to lose weight. But if whenever you are allowed to eat normally, you are likely to come back to the weight that your body is designed to maintain. And this is what is very important. A brief introduction about weight loss surgery or bariatric surgery. Everybody believes that it is about limiting the food intake, it's about malabsorption. But the primary thing that has been found in studies last few years has been found that bariatric surgery works by changing the set point. So if the person had a BMI of 40 before surgery and has come down to a weight loss which is equivalent to about 32 BMI, then what happens is that as the energy expenditure starts going down, because of bariatric surgery, the energy expenditure doesn't go down. It doesn't go down further. Rather, in surgeries, it goes up. So the set point changes because the energy expenditure doesn't go down the same way as it goes after a diet or after a lifestyle change. And same thing applies for nutrition. So the energy intake also changes accordingly. It increases marginally, but it doesn't increases as good as it happens when the person is on lifestyle. So this difference in energy intake and this difference in energy expenditure leads to a new change point or new set point. And this is the reason why bariatric patients, surgeons, of course, should lose weight, as Dr. Chandaliya says. Bariatric patients can maintain their weight much easier than somebody who loses whatever with diet, because the set point changes. And this we are going to talk in number of talks in future. A brief, again, a study which published in 2007, and it's a Swedish obese subject study. It's a 20-year follow-up study now of control patients in conservative management and surgical patient. And what they have found after 10 years, people who are on lifestyle changes, 2,000 patients who are on lifestyle changes, they lost about 7 to 8 kgs, and at 10 years they have lost only about 2 kgs. While those who had a gastric bypass lost about for 38% of their weight initially, and even after 10 years, they are maintaining around 28% weight loss. So this is the reason why bariatric surgery scores long term in selected patients. Obviously, nobody is talking about overweight patients or just obese patients. We'll be discussing them some other time. So, friends, how does bariatric surgery works? Briefly, the classical old model was limiting food intake or malabsorption, and now we are talking of physiological reasons for change of weight after bariatric surgery, like altered GI signal to brain, whether it's endocrine or neuronal, and altered GI signal to other tissues like pancreas and liver. It affects gluconeogenesis. It affects the beta cell sensitivity to a glucose challenge, and that is how it improves the diabetes control in patients. So we'll be talking separately on diabetes control in one of the modules. Now, just to conclude, how does the set point theory works? Set point theory works that with age, as we age over a period of time, with aging and environmental influences, we tend to gain about 2 kg weight every year if we are not intervening. And this continues till a certain age. When we do bariatric surgery, this gives a big push down and brings down the patient here. And then the person may gain the same amount of weight which he would have normally gained if he had no bariatric surgery. So this is again about 2 kgs a year. But this gap of 30 to 40 kgs is because of this intervention here. So this is very important, that set point changes with age by a nominal figure. But when you try to change it with lifestyle changes, it might change, the weight may change, but the set point doesn't change. But with surgery, the set point changes and there is a new line or new the threshold from which the environmental influences and aging influences. I think I am almost at the end. So take home messages: energy balance is tightly regulated to a fat storage set point. There are environmentally mediated failure of this system. So it's not that the just because the somebody has never gained weight in his life will not gain at 40 years and 50 years, like what Dr. Darshika asked later on 50s. Obesity, it can happen because the environmental factors changes and that can fail the system. And all long-term successful treatment requires changing of the set points. And I completely agree, there are a lot of research being done on surgical patients so that we can find out the reasons how the gut hormones changes, how the neuronal stimulus changes. And there are many drugs which have come up, which have shown based on the surgical models to show how exactly, and these drugs can be used in the same way, hopefully in future, for treatment of obesity. So thank you so much. I'll be very happy to take questions before we go to our next speaker.
Thank you so much, sir. We do have questions for you. So the first question for you is, why are weight loss surgeries considered to be more of a lifestyle need than a medical one?
I don't agree with this question. I tell you, 80% of our patients who are coming for bariatric surgery are coming because of the medical reasons. And this percentage is increasing. I get patients from even from Professor Chandaliya and all leading physicians and endocrinologists, mainly for uncontrolled diabetes. People are coming forward. Orthopedic surgeons regularly refer patients before knee replacement for weight loss. Nephrologists are sending patients before kidney transplants for weight loss for a successful transplant. Infertility clinics are sending morbidly obese women who are not able to conceive because the IVF treatment is failing and they want bariatric surgery to be done to improve their hormone profile. So I think there are multiple reasons, and obviously everywhere there are people. Some people do come for cosmetic reasons, for various, and I look down because this is a social stigma, because some boy or a girl is going to get married and she is or he is not getting a good match. So I think those people where it is indicated, surgery has a cosmetic benefit and a social benefit also.
Thank you so much, sir. And since you just mentioned about the burden that the society is facing, I would want you to enumerate on the economic and the psychological burden on the patient due to obesity.
I think this is probably the most important question, Darshika, and nobody ever asked this question. Because by the time patient comes to a bariatric surgeon, the patient has been to 5 or 6 weight loss clinics. Patient has been to health farms 2 or 3 times, and none of them is cheap. Some of them are even more expensive than us or bariatric surgeries, some of the health farms. And the amount of money that has been spent is huge and humongous. And more than the amount of money, I'm more worried about the psychological impact on the person. Because the person and the family starts believing that they are individually responsible for the failure. And that is why I put the first myth that it's not lack of willpower. Just to digress from your question, most of the bariatric patients have given up smoking 10 years back. Most of them have given up alcohol 4 years back. So they are not, many of them have not tasted cheese for last 3 years because they believe somebody has told them. So I never find them short on willpower. But the psychological impact of repeated weight loss attempts and apparent failure, it's not their failure, it's a system, their body is resisting a change, is a big question mark about our conservative treatments. And all the patients who come to us, almost 60% of them, when we tell them that you can lose at least 40 kg weight, they start crying because they can never believe after struggling for 15 years, 10 years, that this is even feasible. So I think there is a big toll on their psyche. And as Dr. Chandaliya said, if they are unsuccessful, so there has to be a line drawn that we will have 2 unsuccessful attempts, 3 unsuccessful attempts, and then stop, and then go for something more definitive like a bariatric surgery.
So we have another question from Dr. Vasava. In a patient well controlled on antipsychotic medicines with irritable bowel syndrome, is bariatric surgery useful in that case?
Wow, Dr. Vasudeva, you are asking real trick question today. So I think it's very important. So this has 2 separate components. It's not necessary that every psychiatric patient has a irritable bowel syndrome and vice versa. So if a patient on a antipsychotic medication is well controlled and is indicated for bariatric surgery because of the weight or diabetes or comorbidities, I will speak to the patient's psychiatrist. And if the psychiatrist says that he or she is well controlled, I'll go ahead with surgery. I don't see any reason. The psychiatric problems are also a disease. Just because somebody has one disease, one compartment of the body, we cannot deprive them of a healthy life in other compartments. So this person has shown that they are disciplined enough to take medication on a regular basis and are well controlled. Now, as far as irritable bowel syndrome is concerned, if you do a surgery which is not touching the bowel, so I will offer a restrictive procedure like a sleeve gastrectomy, and it doesn't worsen the irritable bowel syndrome. But definitely, I have limited choices in a patient with irritable bowel syndrome. But in psychiatric patients, I am not limited by choices. I can offer any of the surgeries. Sorry, I can't hear you, Darshana. Darshika.
Correct. Yeah. So I have an open question for both of you, Dr. Goyal and Dr. Chandaliya. So, sir, obesity is an ongoing pandemic for years and for many countries also. So, but still there are no protocols or guidelines for ideal management, but is also at the higher expense on issue for patients to opt for surgery. What do you have to say about that?
Sir, you first, please.
I think any area where there are multiple treatments overall shows that there is no specific treatment. It goes on that way sometimes for decades and decades until you have a breakthrough. So multiplicity of treatment indicates that failures are very high. So all sorts of people come in, some of them with very good motive of researching, helping people, others to have wealth, this great opportunity. So it goes on that way. The protocols cannot be built up but they should be built up. I think what Dr. Raman Goyal showed very simply, you make some attempts, things don't work, there are additional indications. Comorbidity, for example, sometimes the last milestone is bariatric surgery. Can be considered much earlier to even prevent misery. So I think somewhere we have to balance it out. I think we are not trying to balance out. Each group is promoting its own of, and they sometimes firmly and conscientiously believe in that, and the minds are a little bit closed, minds are not open. So I think it takes some time. So, but it should emerge, I think. Dr. Raman, well, there must be some guidelines out there, some association. He can probably quote some guidelines. At what stage, what should we introduce?
I think
I've not seen.
You have so well summarized the whole thing, that lack of multiplicity of treatment options, and that itself shows that we do not have a solution in sight for most of the people, and so it's more of in Western countries, patients are mostly treated in hospitals where there is a multidisciplinary team, and they take a call that, okay, the patient will be managed by nutritionists and a team of endocrinologists and nutritionists, and they decide that if this one doesn't lose or maintain weight in 6 months, and if this person is suitable for surgery, patient will go for surgery. Unfortunately, in India, because most of the patients are managed in private sector, so patients can go to a private clinic, can get managed by a surgeon there or by a physician, and thus there is so I don't, sir, to answer your question straight, we don't, nowhere in the world there is a laid down protocol, but every multidisciplinary team develops their own set guidelines that we will do this for 3 months. If you want to add medicines, we will add this medicine for 3 months. If it doesn't work, we move to next medicine. And if this doesn't work, we probably go for surgery. So I think, Dr. Darshika, that is to answer your question. As far as cost of the surgery is concerned, there are multiple studies, even from India now, which shows that in most of the patients, the cost of the surgery is recovered between 1.5 to 2.5 years. Because over a period of time, and just a reflection of pharma industry, not the medical side of our profession, the cost of medicines have also gone up, substantially gone up. So some of the patients may be spending 15 to 20,000 rupees for management of their disease like diabetes with the newer drugs, or some may be spending just 1,000 rupees or 2,000 rupees. So it depends at what level of the thing is there. And fortunately now the insurance is completely covering bariatric surgery. So from October 2020, we are now almost 100% covered with insurance, and almost 70 to 80% patients are getting it done through insurance. So that has reduced the cost burden at least. Obviously, the surgery is a surgery and patient has to take a call about it, but cost burden has been substantially reduced.
So before we end the question answer session, we have one more question from Dr. Vasudev. So he wants to know what BMI bariatric surgery indicated, like on what BMI, and what are the absolute indications for bariatric surgery?
Dr. Vasudev, I would love to have you in every session, every Thursday, same time, because we are going to talk about bariatric surgery in detail. Today, it was more of a primer with the leading endocrinologist of the country and our teacher, Professor Chandaliya. Just to briefly tell you about the BMI, I'm not going to talk much about indications, is that the Indian Obesity Surgery Association says that somebody is 27.5 BMI and has uncontrolled diabetes, we can offer them surgery for diabetes, not for weight loss, for diabetes. If somebody's BMI is 30 and has other comorbidities, which could be a severe sleep apnea or, as I said, a renal failure requiring transplant and all, we can offer them surgery or infertility. And then if somebody's BMI is 37.5, then they don't need any scratch of a comorbidity. That is in itself enough to offer them surgery. So these are basically 3 Indian criteria. I will definitely want you to join next time. So I'm holding back the absolute indications. Join us next Thursday and I'll answer this.
Sure, sir. I think we will personally invite him as well if required.
Yes.
So thank you so much to both the doctors for answering questions so well. We also have with us Hema Parmar. Ms. Hema Parmar, who's the patient who has lost substantial weight successfully, and I would like to invite her to share her experience.
Yeah, hello, hi, good evening. Happy Doctors' Day to all my doctors. This is Hema Parmar from Surat. This prayer basically is on, I think, weight loss, which is my subject. Weight loss has been a magical stick for me. I have been always been obese from my childhood. It was a gift from my mom, and she is also facing the same problem. I weighed around 130 kgs at 31 years, and it was a big amount of weight with me. I tried losing weight with diets, gyms, but it was not possible. The weighing scale did not move. Due to my weight, I had many problems facing in my life, physically, mentally. Husband was always wanted a pretty and slim wife. I was always the double of his size. He felt hesitated to be seen with me, but life goes the same way. So even my son would always discourage me to be with him in his school's PTM meetings or any other functions. I was always a depressed, demotivated housewife, could not conceive for a second child. I was just behind my home and houses, not going anywhere. I avoided always social and family gatherings to be away from the undesired attention due to my weight. It was a really depressing part of my life. Whenever I went shopping, I could not fit into any of my jeans or any of my, size clothes. It was just depressive. Then I underwent bariatric sleeve gastrectomy in 2011, and I lost 55 kgs within a year. And wow, that was amazing. My life changed. I had a good experience. I lost around so many kgs. And then my father wanted me to be an independent girl working for myself, for my family. Then I joined Dr. Goel's bariatric program as a patient coordinator. Thanks, sir, for that opportunity. Then I got a lots of satisfaction supporting people facing the same problems in their weight loss journey. That gave me more confident. I became more outgoing. I started enjoying my life. And now I'm working in an orthopedic patient coordinator. So bariatric surgery has always been a magical stick for me to lose enough of weight, be energetic, and I believe losing more weight, being fit, made my confidence level high. I enjoyed my life more happily and helped my family working independently. My younger brother and my mother also have undergone sleeve gastrectomy. They are also being a fit and happy life. And thanks for everything. And I have always been appreciated for what I have achieved in my weight loss program, in my weight loss journey. And now I'm an independent working woman. So this is all, it has changed from pre to post. Thank you.
Thank you, Dr. Thank you, Ms. Hema. I think we just have one question for you.
Yes.
So, like we see, were you successful in adhering to the treatment, or there were times that you also lapsed the entire process?
No. I was absolutely fine with what bariatric surgery guided me, how I should work, how should I move, how should I eat, how should I work, and what should I do. So bariatric surgery has always helped me.
Hima, what she wants to know is, did you have difficult times here where it was difficult to maintain weight? Because now you are how many years after surgery?
It's almost 10 years.
So what
And
there
now I am maintaining my weight.
Yeah. So
Yes,
what
sir.
are there times when you feel difficult to maintain, and how did you manage to change the things again?
Initially, yes, I lost lots of weight within a year, 2, 3 years. I was well maintained. At present, also, I am maintaining on 80, 85 kgs, and it is absolutely easy. You just need to just have a modification. If you'd have to just go a party or anything, it is right to eat at present also. Yeah, the proportion side is yes a bit less, but choose the right ones. You have to, at present also, you need to take a good protein intake, which will help you to sustain that weight so that you don't put on that weight.
Thank you so much. I think that answers our question well. Sir, any closing remarks from your end, or Dr. Chandaliya, any closing remarks from your end for amazing, audience, those who are watching us live and on this occasion of Doctors Day? Would you like to say something to them?
I think this is wonderful what is initiated by Dr. Raman Goyal and his association, because there are a lot of myths and misadventures in this area, and pleasing people, misguiding wrong treatments, quacks abounding, including the farm houses in Switzerland. My patients go Thailand. All those are cheats. So a large number of cheats around. We have to really get people out of these rackets. And I think what you're doing is spreading this knowledge among capable doctor audience here. I think will have an impact on the society to change approach to this problem. So I congratulate you, Dr. Raman Goyal. This is required.
Thank you, sir. So I think Dr. Darshika, first of all, I would like to thank Dr. Chandaliya sir for sparing time to participate in this program. It's when everybody is working from home, the time requirement has gone up, and people are doing more consultations, and it's difficult to spare time. So thank you very much, sir. I think the education is the key to make things more scientific in our country, and the reason why we have a patient in this program of family physicians is, I give you example that when I do bariatric surgeries, some of my anesthetists who have been giving anesthesia for last 10, 12 years, and nurses in my hospitals, they say we only see your patients who, when they undergo surgery, have they lost 4 or 5 kgs or not? So because they never see patients in follow-up. I mean, they see the ward nurses see patients in the wards. Anesthetists see patients on the table when they're 140, 150 kgs. But they never see a patient who has lost 40 kgs and how they look, how they respond to surgery. So I thought this is a good time that family physicians, and I believe this should be done in all the CMEs, that human interaction, the patients must come and narrate their stories. Because even as a doctors, we do not know the stories of other specialties. We only know the scientific data. The human touch to the data is missing. And that is what we are trying to bring in. And only thing I would love that if the participants ask more questions through our piece about what they can eat, how they can eat, what are the limitations, how they exercise, how they maintain. So I think that is the way specialists are questioned about their talks. The patient should also be questioned, and I'm sure they will be more than willing to share their experience. So I think I would thank Doc Plexus for starting this initiative on the Doctor's Day. These platforms have become a major contributor to knowledge spread, and I'm very happy to be associated with the Doc Plexus for a long time. And thank you, Hema, for agreeing to come on a public platform and sharing your experience. It really takes effort and guts to do that. So thank you so much for being here. And over to you, Dr. Darshika.
Thank you so much, sir. I, on behalf of DocPlexus, would like to thank Dr. Chandaliya and Dr. Goel for this insightful experience. Experience sharing on such a basic yet very important subject is lifestyle. We are lucky to have experts like you who support clinical discussions on DocPlexus. Also, of course, a very happy Doctor's Day to both of you. I would also like to thank Ms. Hema Parmar for her time and also agreeing to share her experience on our platform. Also, for our great viewing doctors, we are very thankful for your time and questions and making this event a success. Please log in on DocPlexus for your daily dose of medical updates, and we shall meet next Thursday, same time, for another interesting session along with CMS. Thank you so much, sir, and happy DocPlexus.
Thank you.
Thank you so much.
Thank you.
Thank you.